Thanks and welcome everyone. Yep, recording's in progress. So welcome to our GECO meeting, the Gastro Echo meeting. This week is pediatrics. GECO is hosted by the Gastro Foundation of South Africa in association with Project ECHO from the University of New Mexico. And we hold these sessions every week on a Wednesday at this time. We've received about 45 registrations before the meeting started from 11 countries. And I hope you'll enjoy the session and the chat will be open for questions afterwards. I want to introduce E Losta, who is a pediatric gastroenterology fellow with just 2 months of time to go before she becomes a fully fledged gastroenterologist. She's originally from Libya, but she's been in South Africa for a while, both undergraduate and postgraduate studies, I believe. And she's here with her husband and 2 children. Iman's going to tell us about a very rare condition, but I think it's more important than just the rare condition, because even at the moment we've got a child in our ward with TB peritonitis who's actually got a chylus effusion, and a lot of the management principles will be the same. So Iman, thank you so much for joining us and agreeing to do this, and take it away.
Thanks, Tim. Thank you so much. I will share my screen. Can you see my screen?
Yes, we can.
Can you hear me?
Yes, we can.
Okay, so my topic for today is the primary intestinal lymphangiectasia, and I will focus more like on the treatment update of the primary intestinal lymphangiectasia. So I will start with the case. So the Miss EA, she's a 3 years and 10 months old girl, presented to the referral hospital with a history of vomiting and diarrhea for 2 weeks. Then she developed generalized edema. Her illnesses was not associated with fever, abdominal pain, or rash. So the referral hospital managed her as nephrotic syndrome. However, she did not meet the full criteria for nephrotic syndrome, so they decided to refer the patient for further workup and management. She is the second child of the non-consanguineous parents. Her eldest sister is healthy, and she was born at 10 from uncomplicated pregnancy, with the birth weight and length and head circumference were normal at the 50th percentile. There was no family history of genetic disorder, and she had all her immunization was up to date. She's known with the left arm congenital lymphedema since birth, and also known with the recurrent wheezy chest since age of 1 year. They were managing her as asthma, but she was poorly controlled on the medication. So when arrived to our hospital, her physical examination reveals anasarca, pallor, no jaundice, non-pitting edema of the left hand and arm. She was dysmorphic. She has flat and broad nasal bridge, small epicantic fold, small nasal tip, mild micrognathia, and she also has bilateral periorbital edema on the right side more than the left side. Her weight was at the -1 z-score. She was severely stunted, and her mid-upper arm circumference were normal for her age. All her vital signs were normal, and the other systemic examination was within normal limits. So at this point, our differential diagnosis is she cystic fibrosis based on the recurrent wheezy chest and stunting, or is she protein-losing enteropathy with the history of diarrhea, then she developed the generalized edema? So we investigate the patient further. So she was anemic. She was microcytic hypochronic anemia. The white cell count were normal, but she was lymphopenic with the absolute count of lymphocyte of 1.03. Her inflammatory marker were normal. Her lipid profile, liver function test, renal function test, and the electrolyte were within normal range. She has hypoproteinemia and hypoalbuminemia. Her albumin was 6 grams per liter. And also she has hypoimmunoglobulinemia, especially the immunoglobulin G was low of 3.5. Then we tried to exclude the infective cause. So we did the CMV viral load, which was lower than detected. HIV and TB workup came back negative. Then we checked her urine. So the urine protein creatinine ratio from the referral hospital was 0.17. So based on this result, they managed her as nephrotic syndrome, but all subsequent urine protein creatinine ratio only show minimal proteinuria. Then we wanted to exclude the cystic fibrosis. So we did the screening test. The sweat test came back unlikely for CF. She doesn't have any fecal free fat in her stool. The fecal elastase were low, but this sample was sent on a watery stool. And the stool alpha-1 antitrypsin was 40 milligram per milliliter, which also was normal. And her stool examination was unremarkable. Her chest X-ray was normal. Abdominal ultrasound only showed moderate ascites and no bowel wall thickening to suggest of lymphangiectasia. Her echocardiography was normal. So we decided to go do upper endoscopy for her. So the upper gastrointestinal endoscopy shows no flake appearance of the duodenal mucosa. And the pathology of the affected mucosa demonstrate the mucosal lymphangiectasia with no evidence of inflammation, villus atrophy, or parasite. So this is the macroscopic appearance and the histopathology appearance of her mucosa. Then in the same day, under the same general anesthesia, the patient had a whole body MRI because she had that lymph arm lymphedema, and also we wanted to know the extent of the lymphatic channel abnormality. So the whole body MRI shows significant swelling of the whole left upper limb in the subcutaneous tissue extended from the digits to the left mid-arm. Also, she has prominent lymphatic channel extension from the interosseous region distally up to the brachial region and drain into the axillary lymphatic chain. She didn't have no cyst, no mass, or fluid levels. And she didn't have any distended lymphatic duct on the abdomen. So the cisterna chyli were normal, thoracic duct and the hemiazygous system were normal. She had bilateral neck edema, small pleural effusion bilaterally, and she has ascites in the pelvis. She has minimal edema of the mesentery, but she didn't have any bowel wall thickening in the MRI. So at this stage, we diagnosed the patient with intestinal lymphangiectasia, most likely a primary intestinal lymphangiectasia, because we excluded all the underlying etiology. So I'm just going to go through a few slides from intestinal lymphangiectasia. So intestinal lymphangiectasia is a rare disease that causes protein-losing enteropathy. Clinical symptoms are induced by excessive loss of the lymphatic content, which include protein, fat, and lymphocyte, resulting in hypoproteinemia and edema. And the clinical presentation also depends on the location of the injured lymphatic channel. So it can be a pleural effusion, pericardial effusion, ascites, also can be developed as a clinical feature. And intestinal lymphangiectasia can be classified into a primary or secondary. So the secondary intestinal lymphangiectasia, there is like underlying etiology. It can be cardiac, can be mucosal injury from chemotherapy, infection, or toxic substance. The primary intestinal lymphangiectasia is idiopathic, so there is no underlying cause and is often congenital. So just like I did like this diagnostic flow for the intestinal lymphangiectasia. So if you have suspected patient clinically have intestinal lymphangiectasia, so you will have generalized edema, chronic diarrhea from the history. Then from the laboratory point of view, you have hypoglobulinemia, hypoalbuminemia, lymphocytopenia, which our patient did have, and also the stool will be abnormal for alpha-1 antitrypsin. But in our case, the alpha-1 antitrypsin in the stool was normal, but the accuracy of the alpha-1 antitrypsin in the stool depends on many factors. One of them, the way of they collect the sample, and also maybe it's going to, she has severe hypoalbuminemia, so maybe that's why the alpha-1 antitrypsin in the stool is low. So now once we suspected intestinal lymphangiectasia, we have to exclude the secondary cause, the secondary lymphangiectasia. So we look at the heart, so clinic examination for it was normal, the echo was normal. We have to exclude the malignancy. So her ultrasound did not show any lymph node, so it was less likely. And we look for the infection causes, the stool came back normal, we excluded TB, and the viruses all came back normal. Once we made the diagnosis primary, like suspicion of the primary lymphangiectasia, we have to confirm the diagnosis. So you can do upper endoscopy and biopsy, and you can, like the feature that I showed earlier for the macroscopic appearance and the histopathological features. And then after we confirm the diagnosis, we have to look at the extension of the lymphatic duct abnormality. So if it's the intestine, we can have capsular endoscopy to look at the small intestine distally, a small bowel distal to the ligament of Thales, to see if the intestinal lymphangiectasia focal or diffuse. And when we want to look out of the gastrointestinal, you can do MRI, lymphangiography, and if it's not available, we can do the whole body MRI. So once we confirm the diagnosis of primary intestinal lymphangiectasia and the extension of the disease, now we have to plan on the treatment of the case. So there's a basic, so the first option of the treatment will be dietary modification. So dietary modification is the main style of treatment for the primary intestinal lymphangiectasia. So we have to give a high protein and low fat, and the fat component should be more than 90% medium chain and short chain triglyceride, because they don't rely on the lymphatic drain to be absorbed. If the patient did not respond to the dietary therapy, we have to think of second-line therapy, which can be surgery, radiological intervention, or medication. So to get effective treatment strategy, we have to know the extension of the abnormal lymphatic lesion. So first of all, we have to, as I mentioned, we have to know, is it only restricted to the small intestine, or is it disseminated extensively to the extremity or the third space? And if it's only localized to the intestine, is it focal or diffuse? Because that will affect our strategy of treatment. So if it's only focal intestinal lymphangiectasia, that's mean the presence of abnormal lymphatic channel is in focal lesion. So the surgery can be used to rectify the disease due to the small size of the lesion. So in the past, the surgery was the only method available, but nowadays we have the intervention radiology. So the lymphatic embolization is frequently performed currently. And we have to know the extension of the disease before we go into the surgery. So it's nice to know the lymphatic anatomy associated with each intestinal segment is like before we go to the surgical procedure. And I just show here like the lymphatic drainage of the can I say to the duodenum. So you can see the thoracic duct, the liver, and the liver lymphatic all will go into the duodenum. So if there is any increase in the pressure in the thoracic duct or the liver lymphatic, will lead to lymphatic leach into the duodenum. And also if we have increased pressure of the cisterna chyli, also can cause lymphatic drainage into the duodenum and can present with the features like with the protein losing enteropathy. The second type of intestinal lymphangiectasia is the diffuse type. So what is a diffuse type? That means more than one segment of the intestine is involved with the abnormal lymphatic channel ducts. So that means the surgical and the embolization will be very difficult to resolve the problem. So we have to go to a medication. So the medication is absorbed systemically. So it will be appropriate option for the patient with a wide lesion. And the drug that we have is the octreotide. So the octreotide is a somatostatin analog. It will decrease the splenic blood flow, intestinal motility, and the triglyceride absorption. So therefore, it may be optimum use for the patient with the only intestinal involvement for the abnormal lymphatic. But we have to monitor the adverse effect of the octreotide during treatment, like hypertension, bradycardia, hyperglycemia. That's in terms of the diffuse intestinal lymphangiectasia. For the extensive intestinal lymphangiectasia, so will be the surgery, the embolization, and the octreotide will not work. So we have to think of other option, which is like the sirolimus. So the mode of action of the sirolimus act directly on the lymphatic endothelial cell and change the mammalian target of the rapamycin signaling, which suppress the lymphatic sporting and proliferation and induce the apoptosis. So the sirolimus only but doesn't affect the lymphatic flow like the octreotide and dietary therapy. So it's nice to combine both medication with the sirolimus for the extensive disease. The everolimus is the second generation of the sirolimus, but and he have improved in terms of his pharmacokinetic, but we have a limited of information about the everolimus and the treatment of the intestinal lymphangiectasia. And also we have to look for the side effect of the sirolimus, which is cytopenia, tachycardia, hepatotoxicity, hyperglycemia, and electrolyte imbalance during the treatment. The other medication can use for intestinal lymphangiectasia, the primary type, is the propranolol. So the propranolol is used with the infant and the neonate because there is a difficulty by using the sirolimus. It's a beta blocker. It's used usually for the treatment of infantile hemangioma, and it has the similar action on the vascular, like the vascular endothelium and the lymphatic endothelium. So what is act on the rapidly accelerating the fibrosarcoma kinase and the mitogenic activation protein kinase signaling pathway. So by that, we'll reduce the expression of the vascular endothelium growth factor levels and direct induction of apoptosis of the capillary endothelial cell. So the same mode of action will be done on the lymphatic vessels. The tranexamic acid is also another option for treating the primary intestinal lymphangiectasia in the patient who have increased fibrinolytic activities. And there is 2 case reports involved treatment with the tranexamic acid via antiplasmin therapy and normalization of tissue fibrinolytic activity. So I'm just going to go through this table, which summarizes the drug recommended for a patient with the primary intestinal lymphangiectasia. So the octreotide the indication was for diffuse intestinal lymphangiectasia. So we have in the induction dose and the maintenance dose, and the effect will only appear after 4 weeks. For the sirolimus and the everolimus is used in the diffuse intestinal lymphangiectasia and the extensive lymphangiectasia, and the starting dose will be according to the weight, and we adjust the dose by monitoring the trough levels, which we needed between 5 and 15 nanogram per milliliter, and also the effect will only appear after 4 weeks. For the propranolol, is used on the neonate, as I mentioned, and the infant, and the effect will appear around 2 weeks. The tranexamic acid used when the condition have increased the fibrinolytic activity, and we can measure that by finding high D-dimer, and also the effect will appear after 4 weeks. Just a summary, so that we confirm the diagnosis. If it's intestinal only, we go focal. It's intestinal only if it's focal or diffuse. If it's focal, we go for the intervention or surgery. If it's diffuse, we start with so the dietary will be for the old patient. If it's diffuse, we start octreotide. If it's not working, we'll go for the sirolimus. If it's extensive location, that means there is mediastinum involvement, pleural effusion, pleural, retroperitoneal, or extremity, we'll go for the sirolimus directly after dietary therapy. And we can compound supportive therapy until the efficacy of the medication is verified. Then I looked at this study. So this study done in South Korea in the Department of Pediatric with Samsung Medical Center. And they looked at the individual approach for the treatment of the primary intestinal lymphangiectasia in children. It was a single center experience and review of the literature, and it was a retrospective study. So they looked at the children under 18 years old diagnosed with intestinal lymphangiectasia from June 2000 to June 2020 in the Department of Pediatric Gastroenterology and Nutrition, and it was a retrospective study. They include all the patients who were followed up more than 2 years. The total number of patients, they had 18, but 9 were excluded because they were secondary intestinal lymphangiectasia. 2 patients were also excluded because they lost to follow up, and the 7 patients were included in this study. So they used the capsular endoscopy, MRI lymphangiography, whole body MRI to investigate the extent of the abnormal lymphatic vessels, in addition to the endoscopy and the biopsy. Then the individualized treatment approach depended upon the lymphangiectasia location involved. Then they divided their patient to 3 groups. So group 1 with the focal intestinal lymphangiectasia, group 2 with the diffuse intestinal lymphangiectasia, and group 3 with the extensive type lymphangiectasia. So this is the clinical characteristic of the 7th patient. So 3 of the patients have focal intestinal lymphangiectasia, 2 have extensive, and the other 2 have diffuse. And they also summarize like the treatment modality that used, but I will go into a detail in that. So all patients that involved in this study has managed with the supportive therapy initially. So they correct their electrolyte, they replace the albumin, and they use diuretic. And some patients also required paracentesis and thoracocentesis, and some also need total parenteral nutrition. After they improve, they put all the patient on the dietary therapy, and they supplemented them with the calcium and the fat-soluble vitamin. And for the patient who did not show clinical improvement after 1 to 2 months, then after that they considered second-line therapy. And the second-line therapy, as I mentioned, it will depend on the extension of the disease, of the extension of the lymphatic intestinal lymphangiectasia. For the result, so only 1 patient responded to the diet therapy, and the response came quick, like only after 1 week from the dietary restrict, and the serum albumin came up from 1.8 gram per deciliter to 2.7 gram per deciliter. And this patient had a focal intestinal lymphangiectasia, and also he improved clinically as well. So his symptoms like the diarrhea and the anasarca also improved. But the other 6 patients they responded initially to the strict diet, but after they discharged, because of the poor compliance, they developed like the incompliance, the patient who developed, so they did not respond. Then some patients developed refractory hypoalbuminemia, increased generalized edema, and ascites, despite the dietary restriction of the conservative treatment for 1 to 3 months. So these patients were considered for the second-line therapy. So patient 2 is also focal intestinal lymphangiectasia, has abnormal lymphatic lesion only in the small intestine. So, but it was like slightly broad. So they decide on small bowel resection, and it went well without any complication. And the albumin went up, like which initially was 2, but it was elevated to 4.4 gram per deciliter after the surgery. For patient 3, also have focal intestinal lymphangiectasia. He has had abnormal lymphatic channel only in the duodenum. Initially, they wanted to do a surgery for the patient, but after they had an MDT meeting, they decided to do lymphatic embolization instead of the surgery. So the patient albumin level initially was 1.5 gram per deciliter, was elevated to 4.9 gram per deciliter after 2 lymphatic embolization. Patient number 4 and 5, so these patients who had extensive abnormal lymphatic lesion in their body. So patient number 4 was maintaining octreotide for 1 year. The octreotide seemed to be affected for the 3 months, but the patient's symptom restarted to aggravate again without any specific event, and the drug was discontinued. For the patient number 5, who also had this extensive abnormal lymphatic lesion, he underwent octreotide induction therapy 3 times, but there was no efficacy at all. So because of the repeated hospitalization for both patient and the clinical improvement, like they did not improve, so they decided to start him in the sirolimus. And after they start him in the sirolimus, the clinical improvement, like for the both patient, like shown after 1 month of the use. So you can see the patient 4, you can see after using the sirolimus like for 3 years, he went into the clinical remission after the treatment for 2 years. And he currently on, like when they did the study, he was in the sirolimus for 3 years. And his you can see the albumin is like dramatically improvement. So after they started the sirolimus, before it was 2.3, after they started the sirolimus, it went up to 4.4. For patient 5, who has like severe like refractory lymphangiectasia, his albumin level remained at 3.1 even after they started the sirolimus, but he no longer needed paracentesis, thoracentesis, and also the treatment just started when they did the study of only 4 months. So they still follow up the patient and they will see how he will respond to the treatment. For the patient 6 and 7, they have diffuse intestinal lymphangiectasia. So because they have a prior experience that the ectreotide is not good with this extensive type, so they started them directly in the sirolimus. And if you see the patient responded very nicely to the sirolimus, and the albumin level started to increase after 3 months of the sirolimus use, and the symptoms slowly relieve. And in the same study, they looked at the previous article and the case report were done on the intestinal lymphangiectasia treatment with the second-line therapy. So you can see in some of the study, almost like those patients with the focal intestinal lymphangiectasia, they went to the surgical resection, and all of them went into the remission. For the patient who has extensive intestinal lymphangiectasia, so they started them in octreotide, but you can see they were uncontrolled. Then they decided to add another agent. So some study added tranexamic acid, some started everolimus. So after they added the second-line therapy, you can see the clinical improvement appear. And when they start, like for the tranexamic acid, and also for the everolimus. For the diffuse intestinal lymphangiectasia, they responded very nicely for the ectreotide, and the patient went into the clinical improvement. So I will go back to my index patient. So now we know my patient has extensive intestinal lymphangiectasia because he has intestinal, he has pleural effusion, he has ascites, and she's also dysmorphic, and she has left arm lymphedema. So now we try to tie each of these 3 together, and we see if there's one title can put all these features under one syndrome. So we asked the genetic team to review the patient, and we also looked at the St. George classification for the primary lymphatic anomaly. So this is a logarithm look at the vascular malformation and the primary lymphatic anomaly, but I'm just going to go through the primary lymphatic anomaly. So for my patient, she did not have any lymphatic malformation. So she has a primary lymphoedema. So the primary lymphedema can be syndromic, which can be unknown syndromic or non-syndromic, or can be systemic visceral involvement. So that's what my patient fall into this category. So this systemic or visceral involvement can be multi-segmental lymphatic dysplasia, or can be generalized lymphatic dysplasia, or can be lymphatic related fetal hydrops. So most likely to be generalized lymphatic dysplasia because the intestine, the pleura, she has ascites, she has left arm lymphedema. So lymphedema with the systemic involvement. So the lymphedema may be associated with internal disturbance, like it can be systemic or visceral, of the lymphatic system. So within the thorax, within the abdomen, so can be present with the intestinal lymphangiectasia, pulmonary lymphangiectasia, pericardial or pleural effusion. So under this category, there's 2 types. It can be widespread or patchy. So the widespread, the swelling can affect all the segments of the body, such as that's seen in the generalized lymphatic dysplasia. So there's faulty in development and structure of or the function of abnormality of the lymphatic system that affect the whole body. And one type is the Hennekam lymphangiectasia lymphedema syndrome. The patchy type, usually there's area of swelling, for example, left arm or right leg, which has been named multi-segmental lymphatic dysplasia. So after the genetic review of the patient, the diagnosis of Hennekam lymphangiectasia lymphedema syndrome was made. But this syndrome is caused by mutation in the CCBE1 or FAT4 gene, is inherited as autosomal recessive. It's a rare condition that affects the lymphatic system. They can have lymphangiectasia, lymphedema, and distinctive facial feature, and they also will have intellectual disability and respiratory problem. So the management and the progress in my patient. So the patient got into the dietary modification. She was on low-fat diet with a medium-chain fatty acid. We supplemented her with a fat-soluble vitamin. So when she was still in the hospital, the anasarca resolved and her albumin level did improve from 6 grams per liter to 15 grams per liter. We started her on Bactrim prophylaxis because she still had the persistent lymphopenia. She was getting OT for the left arm lymphedema. She is getting the compressing bandaging, and we will monitor her developmental. We decided to review the patient in 2 to 3 months' time and see how she is. And most likely, she will not respond to the dietary modification, and we have to decide which second line we have to go to. This is my references. I'm just gonna include my presentation that the primary intestinal lymphangiectasia treatment will decide on the extension of the disease. And if you see any syndromic or lymphedema patient with a hypoalbuminemia, just think if there's any underlying syndromic intestinal lymphangiectasia, visceral involvement with that. Thank you.
Thank you so much, Dr. Losta. It was a fascinating case, and well done at working her up. I think it just confirms my beliefs that Cape Town is not in South Africa. So well done. While everyone's thinking of questions, I wanted to ask what dietary, or how did you achieve your dietary therapy? Did you use formulas? What did you use?
So we started here, we were thinking of monogen, or like low-fat diet. So the monogen is very expensive and she will need large amount of the monogen. So we thought of Fribini juice with a low-fat diet, and we supplemented her with omega-3 and omega-6 and fat-soluble vitamin, and we'll see how she will respond. Okay, good. And in terms of the octreotide, probably a stupid question, but would you use the same intravenous form that we use for variceal bleeds? And if so, I think that would be quite prohibitively expensive as well. I'm not too sure. Maybe Dr. DeLacy can answer.
So you will use a smaller dose because it's subcut. So you can't use the intravenous dosing because that's going to be too much volume. So you'll have to use a smaller dose for subcut. And the issue is obviously you'll need parental training so that they can give the subcut injection. This patient is from George Hospital, so is currently following up at George, and she has improved remarkably, but she is going to be complex. And we're also looking at whether she can get embolization for her arm, because cosmetically it's quite a problem because the arm is very swollen and it's very cumbersome for the mom to actually get clothing to fit her because she has to buy clothing for the arm size. So we're looking at whether or not she can get embolization just for the brachial area because of the fact that the arm is quite a problem. So the subcut will be a smaller dose.
Thanks, Ronaldo. Looking to see if anyone else has got questions. Presentation. Thank you, Zina. I think you'll be up next for one of our sessions.
So just from my side, Tim, I think, it's a rare case, but it's really to have an approach to a child with edema. And I think the red flags here was that this child had significant hyperalbuminemia. Even for nephrotic to come with an albumin of 6 is very low. And also to remember that if you're going to do your alpha-1 antitrypsin, as Iman said, you want to try and get the albumin up a bit before you do it, because it might give you a false sense as if it's in the normal range. And then also lymphopenia on the peripheral smear is quite an important sign in these patients. So if you have a child with significant anasarca, hyperalbuminemia, and lymphedema, you need to think about intestinal lymphangiectasia.
Yeah. Would you think of doing serum alpha-1 antitrypsin at the same time?
Yeah, you should do a clearance. So to do a serum alpha-1 at the same time as what you do your fecal. And it's important to actually, if it's very low, the albumin, to try and bring it up a bit. So to give some albumin and then do it.
Sure. Great. Thank you so much. I hope I'm not missing any hands. There's 2 screens. Okay, no, I don't see any. So I think then I can close the meeting. I want to thank everyone for attending. I want to say a big thank you to Dr. Losta for this excellent presentation. I really enjoyed it, and I think you made it a difficult subject very, very clear. Thanks to ECHO New Mexico and the ECHO India team. There is a feedback form available in the chat, so it would be great to get some feedback from you guys. And if you know someone that missed the talk, it will be available on the Gastro Foundation website. Thanks to the Gastro Foundation and the sponsors. And I think next week we will be doing an endoscopy quiz. Sounds exciting. Thanks, everyone.
Thank you.
Thank you, Tim.
Thank you.